Hello, I'm Dr. Ian Paul, and this is an introduction to Medical Neuroscience and Behavior 2 for the academic year 2021-22. To begin with, welcome. We've worked hard developing this course and look forward to working with you this year. Today, I want to describe the course objectives and structure, explain important policies, and describe how we teach this course. Finally, I'll talk to you about grading for the course. As I mentioned, I'm Dr. Ian Paul, and I'm a professor and director of medical student education and psychiatry in the Department of Psychiatry and Human Behavior. The course is coordinated by Mrs. Barbara Daniels and Mrs. Ashley Smith. When you need to ask questions about the course, I recommend that you always copy the Psych MSc email. We all have access to that mailbox, so if one of us is out, the others can field your question and route it to the right person. Medical Neuroscience and Behavior 2 is a systems-based M2 course focused on abnormal structure and function of the nervous system and behavior. It integrates material from psychiatry, neurology, neuropathology, CNS pharmacology, and neurosurgery. In the medical neuroscience sequence, it follows the M1 medical neuroscience course, which focuses primarily on normal structure and function. In addition to being horizontally integrated within the M2 years, Medical Neuroscience and Behavior 2 serves as a vertical bridge between the largely basic science M1 courses and your clinical experiences in the M3 year. After completing Medical Neuroscience and Behavior 2, you should be able to demonstrate knowledge of the signs and symptoms of common neurological and psychiatric disorders. You should be able to conduct a neurological exam and a psychiatric interview in encounters with patients, and identify relevant signs and symptoms. From that information, you should be able to formulate diagnoses and appropriate treatment interventions. Prior to 2015, most neuroscience-related content was presented in lectures, with the students assuming a relatively passive role. Over the 4 years from 2015 to 2019, student learning was shifted to more active-based learning, but still relied heavily on lectures. 3 years ago, we began using a flipped classroom approach where almost all class time involves active student participation. So why change? There are a lot of reasons driving the shift to a flipped classroom. The biggest reason is that we wanted to make careful use of modern adult learning theory. In addition, we wanted to adapt our teaching to the way your generation learns, which is quite different from previous generations. We also wanted to put the students in the driver's seat as far as how and when you acquire your foundational knowledge, so that we can use class time to focus active clinical problem solving. A flipped classroom makes use of the features of andragogy. Students engage initially with material in a self-directed way to obtain foundational knowledge. A content expert reviews and assesses student learning, fills in gaps, corrects misconceptions, and introduces students to the application of their foundational knowledge in problem solving. Finally, students apply their learning with guidance as needed in independent or semi-independent problem solving, preferably in settings that mimic real life. In Medical Neuroscience and Behavior 2, students engage with the factual content via online presentations in Canvas that are accompanied by self-testing. Students then engage with clinicians in guided case analysis using between 3 and 4 interactive cases in a large class environment. Finally, students engage in individual practice by examining standardized patients in a small group setting. Students are coached and guided in that setting by the small group facilitators. The general format of Medical Neuroscience and Behavior 2 is 13 general topic blocks of 1 or 2 weeks each that begin with self-directed learning and a problem-based learning assignment, and proceed to guided case reviews, and finally small group work with standardized patients. This year I've been able to cluster most of the large class meetings and small group sessions on the same day so that students only have to commit 1 day a week on campus for the course. This course is organized into 13 topic blocks. A topic block contains several units covering related material. The course begins with 6 topic blocks in neurology that open with pain and pain management. The rest of the neurology topics are neurotrauma, seizure disorders, movement disorders, neuromuscular and demyelinating disorders, and stroke and vascular diseases of the CNS. The transition to psychiatry begins with neurocognitive disorders and is followed by mood disorders, stress and trauma-related disorders, anxiety disorders, psychotic disorders, substance use disorders, and neurodevelopmental disorders. Each topic block consists of 3 or more units. The individual units cover the pathology, symptomatology, diagnosis, and treatment of a group of related disorders. There are 13 topic blocks on Canvas which cover related topics like this one on neurotrauma. As noted in the previous slide, within each topic block are a number of individual units covering those individual topics. This year, we're working hard to convert the old 50-minute lecture-based material into multiple smaller units of about 15 minutes each. These units are converted to video and loaded into a YouTube library, which can be easily accessed on whatever device you happen to be using at a particular time. At the top of the module, there's a link to a YouTube playlist of all the videos created from the narrative PowerPoints. There may also be a link to relevant osmosis pencasts. A unit has several components which I'll go over in the next slide. After 1 or 2 units, there's a 4 to 5 question formative quiz. Each unit normally consists of 4 elements. First, there is a study guide which indicates the author of the material in the unit, a description of the unit's material, and recommended reading. Next is an optional readiness assessment test, or RAT. This is a short test that helps you check whether you have the necessary background for the teaching material. When you get a question wrong, the RAT suggests what you should review. The third element is what I refer to as asynchronous teaching material, or ATM. This includes individual links to narrated PowerPoints and an unnarrated version that you can use for note-taking. It may also include a link to osmosis pencasts, written supplements, and self-tests. Finally, the unit finishes with a formative quiz. These quizzes are short, usually 4 to 5 questions that focus on critical takeaway concepts from the ATM. They're usually simple multiple-choice questions focused on factual knowledge, as opposed to the exam questions, which usually are in the form of clinical vignettes. Each quiz is worth 1 point toward a 120-point cumulative exam, so each question is worth no more than 1/5 to 1/4 of a point. This is a good way to check that you caught the most important information in the unit. Each formative quiz is worth a total of 1 point toward a cumulative exam grade, and there are about 60 formative quizzes. At the end of every even-numbered block, there will be a 10-point, 10-question quiz. These questions are samples of exam questions and should help you prepare for the 3 exams in the course. These will be administered in the first 15 minutes of the PBL session for that week. About a week before class time for a topic block, I will open a problem-based learning assignment. You'll work in the teams Dr. Stray set up in microbiology, identifying the relevant facts as they're presented, formulating hypotheses, identifying missing information needed and what that information will tell you. Every few days, additional parts of the case will be revealed to help you narrow your differential diagnosis. While the information in your worksheets will not be graded per se, I'll only award credit to appropriately updated and completed worksheets. Each completed PBL is worth 1 point for each team member toward the final grade. In the first hour of class days, a clinical expert will review the case and describe her or his thought processes as the information was revealed during the assignment. In the large classroom sessions, the PBL session will be followed by guided case reviews. In these, clinical content experts will walk you through diagnosing and treatment options for 2 or 3 cases based on the topics you studied for that block. Attendance is mandatory, and the cases include Nearpod questions which help the person leading the case review know when there's a concept that people are having difficulty with, so that more time can be focused on explaining the concept. In order to keep the class time interactive, cases are available to you on Canvas on the day of the class, but will have the answers stripped out. After class, the cases with the answers will be available on Canvas. There are 9 small groups for case-based learning composed of 3 to 4 of Dr. Stray's small groups. During each session, 2 student doctors from each case group will interview a standardized patient. The standardized patients each present with the symptoms of one of the disorders covered during that week's topic block. This means that in each small group session, the student doctors will examine 2 different standardized patients. A case group facilitator will help coach the student doctors as needed and discuss the case with the group after each patient is examined. These faculty and residents are fantastic resources for you to answer questions and give you real-life perspective on the disorders presented as well as their treatments. You should all obtain the appropriate tools for neurological exams. The neurology department recommends that you get a Tromner-style reflex hammer rather than the tomahawk type for more precise reflex testing. A 128 Hz tuning fork for testing vibration sensation, a Rosenbaum-Snellen type pocket eye chart rather than the one in Maxwell for visual acuity testing, and some wooden-handled swabs which can be broken to test touch sensation and then discarded. All of these tools are usually available in the UMC bookstore, although they may have limited supplies. However, you can purchase the complete set for about $50 from online retailers like Amazon. The psychiatric examination tools are a bit different and can be found in the Canvas module called Exam Tools. I recommend that you review the SIU School of Medicine Guide to the Mental Status Exam. Not only does it give you a detailed description of each part of the exam, it also provides you with a great brief glossary of terms used to describe the signs and symptoms observed in the examination. There's also a great one-page checklist for the mental status exam that will make organizing your exam notes easier. I recommend printing it and carrying it with you when you're one of the student doctors. In addition, in that module, there's a copy of the Folstein Mini Mental State Exam. Bear in mind that the MMSE is not the same as a full mental status exam. The MMSE focuses only on the patient's orientation and overall cognitive function. I recommend printing it along with the document labeled Intersecting Pentagons and Written Command. These will make conducting the MMSE faster and easier. Finally, when you're assigned to be a student doctor, remember to bring a blank sheet of paper and a pen for the patient. Small group time is divided into roughly as in this table. After each student doctor examines an SP, the facilitator will provide ungraded feedback and coaching. In addition, the facilitator will invite the rest of the group to discuss the case and any questions they have. Following each session, the student doctors will prepare and submit a case write-up to both my email and to the Psych MSE email. These are due 7 days after the CBL session. For case discussion, first of all, remember that you should be driving the conversation as much as possible. Facilitators are trained to avoid providing their own diagnosis or differential, but they may provide hints, statistics, as well as comments about the disorders in the block's theme. This is also, again, a great place to ask questions. And remember, you'll get much more out of these sessions if you get in there and take a chance of being wrong. Nobody's grading you on your discussion. Because we have more cases than students in each group, there are 5 to 8 extra student doctor slots in each small group, divided between psychiatric and neurological cases. We've randomly assigned some of you to the extra slots. If you've been assigned as a student doctor twice, you're not required to submit a case write-up on the second standardized patient, but you can, if you wish to, for extra practice. I'll review it and give feedback on the second write-up, but it won't contribute to your grade. If you are one of the students assigned only once as a student doctor and you especially want to conduct a second exam, feel free to approach one of the students in your group assigned to 2 exams to arrange a trade. This might be particularly useful if you weren't assigned to a neurological or psychiatric exam and would like some experience. The grading rubric for the case write-ups looks for the presence or absence of the necessary elements of a case note, such as chief complaint, history of present illness, etc. Do your best on the style, but that doesn't affect the scoring of the individual components of the write-up. Look for constructive criticism and suggestions for improvement. Those don't affect your grade, but I'll include them to help you develop your skills. Overall style, based on clarity, conciseness, and focus, is graded separately from the individual components. When you're ready to turn it in, email copies to both me and to the Psych MSE email address. Here's an example of the grading rubric. Over the last 3 years, opioids have been prescribed at the rate of almost 3 prescriptions for every 1 person living in Mississippi. Opioid overdose deaths in Mississippi have more than doubled over the past decade, and opioid use disorder is very common, particularly in non-urban areas where treatment access is very limited. One of the best treatment approaches to opioid use disorders is medication-assisted treatment, or MAT. However, MAT requires an X waiver on a DEA license to allow for prescription of drugs such as Suboxone. Holders of this waiver are very scarce in exactly the rural areas where they're needed most. However, an X waiver requires training and certification. One goal of this course is to make sure each of you has the training and certification for an X waiver, if you choose to get one. PCSS offers medical students a free 8-hour training course, and while you don't have to use your certification to obtain an X waiver, this certification is sufficient to do so. Performance on this is ungraded, but you receive 5 points toward your final grade for turning in a copy of your certificate of completion to the Psych MSE office within 1 week of the end of the course. This is a breakdown of the grading. The PBLs together are worth 13% and your case write-up 5%. The formative quizzes and block quizzes together are worth 12%. Your completed and submitted PCSS certificate is worth 5%. Exams 1 and 3 are weighted lower than Exam 2 because Exam 2 covers a little more content than the other 2. The board exam is a custom exam designed around the content of the course and is worth 10%. Your participation in the IPE activities is worth 5%. You can see that between the PBLs, the case write-up, the PCSS certificate, and IPE participation, over a quarter of your final grade is simple pass-fail. All you have to do is complete the assignments. Let's take a moment and talk about my course policies. Communication with a class this large can be a challenge. I will expect you to have read the syllabus and reviewed the calendar by Monday, November 8th. This is a great time to identify conflicts with your schedule and let me know. Almost all communication comes through Canvas announcements in UMC email. Check your email every day. It's always a good idea to send your questions in duplicate, with a copy always going to the PsychMSE address. I try to answer all emails during the week within 48 hours or by the next business day if you email me on the weekend or a holiday. All the modules are on Canvas. As I mentioned, we're trying to revise all the units in the modules into short videos of about 15 minutes each. I've asked all faculty to send the material to me so that I can make sure they're posted at least 2 weeks ahead of the due date. Except for the November 11th GCR, all assigned modules are due by the topic blocks GCR class. For November the 11th, just complete the neurological exam module. Units completed after the GCR class will forfeit the points from the formative quizzes. Because the course heavily involves clinical faculty and standardized patients, all classes are mandatory. Because you will be examining or watching the examination of SPs, small group attire is a lab coat and professional attire or scrubs. I realize that many of you have already had to arrange time off campus for education, research, or career development reasons. Just send me an email to let me know that you'll be absent and why, and send a copy to PsychMSE. If you're absent on a day that you're assigned as a student doctor, it's your responsibility to arrange a trade with someone else in your group and to let us know about the trade at least a day in advance of class. I also realize that life happens. Rather than force you to invent sick or dying relatives, each of you has 2 get-out-of-class free cards. Each covers 1 class day. If both the large class session for PBLs and GCRs and the small group sessions are on that day, your card covers both. However, if they're separated in time, your card only covers the day you're absent. Again, notify me at least 1 day in advance. For the 6 quizzes and the 3 exams, any material listing in the Canvas modules as required or material discussed in large class sessions is fair game. Most questions are written in NBME style, that is, a clinical vignette with one best answer. I have a large curated question bank that's allowed me to weed out most of the bad questions over the years and to have stats on how difficult each question usually is. The problem with receiving new questions every year is that I don't have time or expertise to spot all the duds or to gauge how difficult a particular question is. As a result, I don't post exam questions and answers after the test. However, you're free to review the exam for specific questions in the PsychMSE office by appointment. However, if requested by the class, I will arrange a special review session after the exam. I normally go over any question that more than 30% of the class got wrong. If there are particular questions that you'd like discussed, let me know and I'll try to include those as well. Challenges should be written and justified and submitted through your class liaison. Thank you so much for your time and attention. I look forward to working with all of you this year.